Okay, welcome back. We've been talking about general conditions and expectations in the first part of this training. In the second part, we'll be looking at the actual delivery of services. One of the most exciting things about family preservation services is that each intervention really is different from every other intervention based on that family's strengths, their challenges, their specific situation, their needs, their goals, their culture and values, and so on. The effective therapist is going to use his or her own experience, clinical skills, and unique individual strengths and abilities to determine the best way to approach each family's and each intervention. Children's Administration also provides specialized trainings to make sure that the services that we provide are consistent and effective. For example, all FPS therapists and paraprofessionals receive training in motivational interviewing, or MI, which is defined as a client-centered directive intervention that focuses on enhancing intrinsic motivation by exploring and resolving client ambivalence. It's considered to be an EBP, or an evidence-based practice. In addition to motivational interviewing, other EBPs are also being explored, and specific practice applications for FPS are being developed. An example of an evidence-based practice is the Positive Parenting Program, or PPP. This model, as well as some others that are being explored and that are designed to meet the needs of FPS families, are going to be included in a menu of potential service models. When EBPs are incorporated into the service contract, FPS therapists will then be required to use those models with all families whose presenting problems fit the model. And Children's Administration is going to also provide training, just like they currently provide training for motivational interviewing. They'll provide training for all EBPs that are required under the service contract to ensure fidelity to the model, in addition to introducing people to these various models. But regardless of whatever practice model or clinical approach you use as an FPS therapist, there are a number of steps which must be taken and certain tasks that have to be completed with each and every family you work with. So let's take a look at some of these different tasks, some of these different requirements that are going to play a part in every FPS intervention. So far, we've been talking about the kinds of things that take place up to your meeting the family. One of the things that we've already addressed is that the contract states that face-to-face contact must take place within 48 hours of the receipt of the referral. And I want to elaborate that this means regardless of the time or the day that you receive the referral. So if a referral comes in at 7 p.m. on a Friday afternoon, you have until 7 p.m. Sunday afternoon to make your first face-to-face contact with that family. Now, if the first meeting, for whatever reason, can't occur during that time, within the 48 hours, your responsibility is to notify the referring social worker as quickly as you possibly can, but definitely within the 48 hours, that you're not going to be able to meet with them. Yes, here's a question.
So is there ever an instance where a referral will come in and say the date of the referral might be October the 1st, but say you don't get it until October the 2nd, we still have to go by that date that is on the referral?
Yes, that's a very good question, and that's exactly what the expectation is. So each provider who agrees to take an FPS contract is in essence saying, our agency agrees to have some mechanism in place that will allow us to meet with clients within 48 hours. One thing that frequently creates problems for agencies is, it's not uncommon for referrals to come in on Friday or even Saturday or Sunday. Technically speaking, after-hours workers have the ability to make FPS referrals. Your agency has agreed that you will have some setup in place so that you can be prepared to respond to referrals that come in outside of Monday through Friday, 8 through 5. So yes, that is the expectation. Now, another thing that has to take place in that initial face-to-face meeting with the client is that at least one primary caregiver needs to sign a voluntary consent form provided by you, the FPS therapist. There is no state-required voluntary consent form, so typically each providing agency has developed their own. Voluntary consent forms or voluntary service agreements can be called several different things. They can also include a variety of different information at the agency's discretion, but they, at the very least, have to include an acknowledgement that FPS is a voluntary service and that the client is voluntarily choosing to participate. Now, some agencies actually include other types of information, perhaps a statement of client rights, perhaps an explanation of their status as mandated reporters, perhaps a therapist disclosure statement. All of those things are acceptable as long as the client signs something stating they realize the services are voluntary and they are agreeing to participate. The next thing that the therapist is required to do in that first face-to-face visit is, if the referring social worker completed a safety plan and attached it, then you must review it with the family. Now, when we talk about family safety in the third training module, we'll elaborate a little bit more on what's good about safety plans, how to make them really work, and so on. For now, I just want to point out that if you have a safety plan that you received from the referring social worker, you must review it with the family during that first face-to-face meeting. Now, if no safety plan was completed, but while you're meeting with the family, you become aware of safety concerns and you feel a safety plan needs to be in place, it's not your job to tell the social worker what they need to do, but it is your job to contact the social worker to let them know what these safety concerns are. And if these are CPS issues, you also need to notify CPS intake. So let me give you an example of what a difference might be. Let's say you go to a family's home and you notice that there is a huge sinkhole in their front yard. And this family has 3 children under the age of 5. Okay, is this gigantic sinkhole a safety concern? I suspect it probably is. Maybe there was a broken water main, maybe the city came in and started moving gas lines or something like that. At any rate, there's a great big hole in the yard. It's a safety concern. Is it a CPS issue? It wouldn't be, because the parents are, if the parents are doing what they need to keep the children away from it, if they've tried blocking off the children's access, if they have locks on the doors, child alarms, or things like that, then CPS doesn't need to be involved in this. But if you get to the home and there is something like, for example, there's a broken window because mom and dad were having a fight and the child is sitting right next to it and mom says, "Oh, come on, Sam, you know better than that," and they don't seem to be making any effort to fix the broken window. that could probably be considered a CPS issue. There is something going on that jeopardizes this child's health or safety. Parents aren't making an effort to protect them or correct the situation. So use your discretion as a therapist and as a mandated reporter, but not all safety issues are CPS issues. If you do notify the social worker of these kinds of social or safety concerns, be sure to follow up with written notification within 24 hours. Now, the contract states that the CA safety plan, the safety plan completed by the referring social worker, needs to be reviewed with the family at least every 2 weeks. And you need to document that you've done this in the client file. You'll also be having weekly contacts, updates with the social worker, so that's the type of thing that would also be mentioned in those weekly updates. Any new safety concerns that you find or learn of during the intervention need to be immediately reported to the referring social worker and followed up in writing within 24 hours, as I just noted. And as I said, safety plan status is one of the things you'll be talking to the social worker about during those weekly updates. Please note, remember that the requirement that I'm talking about right now is only related to safety plans that were generated by the referring social worker. You also have the right and the ability to develop a safety plan to use with your clients, but that's not contractually required. It also doesn't affect the requirement to review and utilize the Children's Administration safety plan. We'll talk about safety plans more when we get into the safety training module. Now, one question that new providers frequently ask is, well, how often am I expected to meet with my clients? And that is completely up to you, and you'll decide that based on a number of different factors. But there's no requirement in the contract as to how frequently client meetings need to occur. Generally, a good rule of thumb is you'd like to be able to lay eyes on the client at least once a week, either you as the therapist or your paraprofessional if you're using one. But of course, you'd be seeing them more frequently if there's a need for crisis intervention. You're also going to be spending more time with families when you're in the early stages of the intervention and when you're developing the family assessment and the service plan. So frequency of meetings, how often you're going to the client's home, generally is going to vary according to the family's specific need and the requirements of their service plan, where you are in the intervention, because typically you're going to be spending more time with the family earlier in the intervention and less time as time goes on and the family's getting healthier and less in need of your support. And also the amount of the allotted funds that still remain in each case. Now, case meetings is another activity that's specifically noted in the contract, and case meetings refer to meetings related to the case, not necessarily meetings with the family. In essence, you are expected to attend any types of case-related meetings requested by the social worker or anybody else from Children's Administration involved in the case. Also, if you've been asked to attend a case meeting and you're not able to, it's typically expected that you submit some type of report. So if the social worker asks you to complete any kind of report for a meeting, the expectation is that you will do that. Case meetings can include, but by no means are they limited to this, Child Protective Team meetings. Now I'm talking about CPT meetings specifically related to your case, not that you're a general community member of the Child Protection Team. any prognostic staffings related to your case, any LICWAC meetings, case review staffings, family unity meetings, family team decision-making meetings, anything like that would be an example of a case meeting that you would be expected to attend if the social worker requests you to. Now, sometimes people say, am I going to be expected to testify in court? You know what? You probably will. With at least one case, maybe with a lot of cases, you may be asked to testify in court as to what's going on with the family. You may even be able or be asked on some occasions to provide opinion or testimony as to certain events that you may have witnessed or obtained information about. It's not infrequent for you to be asked to provide some sort of a court report. It is your responsibility to do this, and I guarantee you, you'll end up getting quite comfortable with it. Let's talk a little bit about child and family team meetings because they are specifically mentioned in the client service contract. A child and family team meeting basically gathers everybody who's involved with a case. Typically these are going to be other providers of services, but they could be people like neighbors, friends, extended family, and so on, in addition to other providers of service. The child and family team meeting almost always includes you as the FPS therapist, the referring social worker, family members as would be considered appropriate, and representatives from other agencies working with the family. The purpose of these meetings really are to make sure that everybody's working on the same page, operating under the same game plan. Everybody involved with a family's well-being have a similar goal, helping the family to reach a certain point. The social worker may not specifically request such a meeting. If they do, it's your responsibility to set this up. But if they don't, and you think it would be a good idea, you're still welcome to set this up yourself. I might point out that actually convening a child and family team meeting is frequently not an easy thing to do because you have to, first of all, have a time and a place, and then try to get everybody there at the same time and place, which can involve a lot of footwork and phone work and so on. But these can be extremely helpful meetings. Now I want to go on to talking about the family assessment, which really is one of the most important pieces of work that you'll be doing with a family. And in fact, I might also throw out here that when documents generated by FPS therapists are subpoenaed in court cases, the family assessment is one of the documents most likely to be subpoenaed. Another one, of course, is the exit summary, which gives basically a summary of everything that you've done with the family. But family assessments are quite frequently provided as evidence in court cases when they occur. Each FPS therapist is required to conduct a thorough family assessment with each family referred for services. And the tool we use for this is, as I mentioned earlier, the NCFAS, the North Carolina Family Assessment Scale. It needs to be used with every case. Now, the NCFAS, which is used in placement prevention cases, contains 5 domains. These domains are environment, parental capabilities, family interactions, family safety, and child well-being. Each domain lists a number of items within it. You score each of them individually, and then you determine an overall score for each domain. Now, I mentioned that the NCFAS is used in placement prevention cases. Well, there is also a NCFAS to be used in reunification cases, and it's called the NCFAS-R. It's identical to the NCFAS. It contains those first 5 domains I just mentioned, plus there are 2 additional domains that only apply to reunification cases. They are caregiver-child ambivalence, and this refers to not ambivalence about receiving services, but ambivalence about the reunification. And the last domain is readiness for reunification. Just like with the NCFAS, the therapist scores each item in each domain and then determines an overall score for each domain. And these are considered the intake scores. When you close the case, you'll administer the NCFAS again and then compare those exit scores with the intake scores. Yes? Question?
So are there 2 NCFAS reports, or is it just one with 2 additional domains for reunification?
You know, it's kind of all the same thing. You can consider, I mean, you'll have access to them in separate form, but the first 5 domains of the NCFAS are identical to the 5 domains of the NCFAS. There's no difference between them at all. Okay? So if you wanted to make a copy of only one document, you could technically use the NCFAS-R and then just address the first 5 domains. Okay? Now, during the first 20 days, and we're talking 20 calendar days, following that initial face-to-face meeting, the therapist gets acquainted with the family, doesn't necessarily sit down asking questions like on a checklist and goes down one by one, but really you sit down and you talk with them and you observe. You pay attention to what's going on around you. You look at the neighborhood. You ask questions about how things are going. You get comfortable with knowing this family and their situation, what they see as things that they want to change, what you see as their strengths and what they see as their strengths, and so on. You may ask them specific questions, but you would never go into a family's home with a checklist and grill them with one question after the next. Essentially, the NCFAS was designed for the therapist to go back to their office after meeting with the family, take some notes, and then go through and look at these specific items and decide where you might rate the family based on the information that you've gathered. When you have enough information to complete a family assessment, you go ahead and score the family on each one of these items and domains. I do want to point out that there is no minimum or maximum number of hours that you must spend on the family assessment. And that means either with them face-to-face or the amount of time it takes you to actually score the NCFAS and complete the family assessment. After you've scored all the scales, you then complete a narrative report and submit it to the social worker within 20 calendar days. Now, this is less than 3 weeks, so the time goes by very, very quickly. And in FPS, you could have 9 other cases. So you may not have enough time to spend more than an hour or two per week with each family before you have to have the family assessment completed. So it's important that you really focus on gathering the information that will be needed for you to accurately complete the NCFAS. So as I mentioned, you complete the scoring, you write a narrative report, and you submit it to the referring social worker, all within 20 calendar days of that first face-to-face contact. Now, currently, each provider has the flexibility to use whatever format they want in creating that narrative report. So some agencies use like a like a multiple choice checklist with a little bit of a narrative. Others use a sort of a form like a court report or something like that. However you do it is up to your agency, although you might actually ask the referring social worker what format they prefer. But regardless of what format you use, you must include at least the overall domain scores of the NCFAS. So the written family assessment is going to pull heavily from those scores that you've obtained on the NCFAS. That helps you to be more organized also, and it helps to make the family assessment a more usable document because it's going to contain not just subjective, oh, I think they're doing pretty well in this, but a lot of specific objective material. So the NCFAS, or NCFAS-R, depending on which one you're using, and the written family assessment, in conjunction with the information that you received from the social worker in the FPS referral, those things are used as the basis for the service plan. And it's also used to determine what kinds of outcome measures you'll be using for services services provided to the family. So in other words, based on what you've identified as problem areas or risk factors or challenges for this particular family, those are the kinds of things you're going to be assessing at the conclusion of services to determine where progress has been made or not made, as the case may be. So now the NCFAS is also completed a second time, as I mentioned, when the case is closed. This time, you are not going to be asking the family specific questions typically. You are going to be sitting in your office, probably preparing to complete the exit summary. And then for the exit summary, you're going to, as I mentioned earlier, compare those exit scores with the ones you obtained when the case was first opened. By looking at those, you can determine where progress has been made. And of course, the information is reported in the exit summary. You know, I just want to throw out, each of you will go through, if you haven't already, a fairly intensive training on using the NCFAS. But I want to point out a couple of things because they are addressed in the contract as far as other uses of the NCFAS goes. Anytime you receive clinical supervision or provide supervision to a parapro, you should be using the NCFAS scores as a basis for that supervision process. So your supervisor can look at areas where there are obvious strengths or obvious challenges and ask what you are doing in those particular areas, how those areas are being addressed. Or they can come up with ideas or suggestions that might enhance your work with that particular client. Another time the NCFAS would be used is if you've been working with a family and you're leaving the agency, or for some reason this case needs to be transferred to another therapist. In that meeting with the second therapist to transfer the case, it is required by the contract that you sit down with the NCFAS scores, go over them specifically, and talk about how that ties in with what work is being done in this particular case. Specifically, how it ties into the service plan, what goals have been accomplished or are being worked on, and so on. As I mentioned, I'm giving you just a little bit of information to pique your interest in the NCFAS, but you will be going through specialized training so that you will be quite competent in the use of this particular instrument. If you have any questions about what the requirements are, we'll be talking about them a little bit later when we address program requirements. Okay, so let's go on and start talking about the service plan. Now, as if you didn't have enough to do in the first 20 days of working with a family, it's also required that you complete a service plan for them. Now, this is, you work on the service plan at the same time as you're getting the information for the family assessment, but based on the information you're gathering, you're certainly going to start getting an idea of what kinds of goals the family might be wanting to work on. Or if the family doesn't have any ideas or they're not clear exactly what a goal is anyway, this is going to be giving you some ideas for suggestions of service goals to be working towards. As I mentioned, this is also due within 20 calendar days. The service plan addresses needs and it builds on strengths. FPS is a very strengths-focused service. So one of the first things you're going to be doing, maybe even before you start talking about those problem areas the social worker has identified, is you're going to be helping the family come up with a sense of where their strengths lie. And then you'll be helping them capitalize on those strengths, building on them to address any sorts of weaknesses, problem areas, challenges. I never like to use the term problem areas. I always prefer to think in terms of risk factors or challenges that the family may be facing. The service plan is always developed with the family. It's never developed for them. It's very important that you take into consideration their unique strengths, their challenges, risk factors, needs, their language, the way they say things or see things, and always keeping their culture in mind. I can't overemphasize how important it is that these, kind of one-size-fits-all service plans. Some agencies use the same service plan with every single client they meet. Now, hopefully none of those agencies are providing family preservation services, but that's never something that we do. Each FPS service plan is uniquely designed to fit that family's strengths and needs. You're going to want to include input from a lot of different sources if it's available to you, especially from the referring social worker, but from other sources if possible. If you have permission to have contact with a child's teacher, a parent's probation officer, somebody else who's involved in helping this family, then incorporate that input as appropriate into the family service plan. Keep in mind that families may not agree with the reason why they were referred to family preservation services, but it is important that your service plan still has to be consistent with and supportive of the referring social worker's case plan. And sometimes that can create quite a challenge for you as the family preservation therapist. Families may not want to have anything to do with that. Your job is to be the advocate for the family, but you always work side by side with and in collaboration with the referring social worker. Once you've completed the service plan, you and the family have developed a list of goals and objectives, and they're comfortable, they've agreed, they can do these specific things, and they've helped you decide who can do what and when it will be done by, and so on. What I recommend is when you're working on this with the family, it's probably a fairly casual, informal setting. You may be just jotting down notes. I suggest that you take that back to your office when you see the final form of it, type it up so it looks nice and pretty, and then take it back to the family and get everybody's signature. You should get the signature of everybody who's actually addressed in the service plan, especially if they're adults or adolescents. Sometimes younger children will want to sign the service plan, and maybe they can't even sign their name yet. I frequently let them do that. It helps them to feel more a part of the whole process. You should sign it, then you should forward it to the referring social worker for their approval. Now, I want to point out a couple of things about how to write a good service plan, how to develop a good service plan. It should clearly identify the goals of service as related to concerns that were noted in the FPS referral. So there needs to be a direct connection between the service plan that you and the family develop and the reasons that they were referred for services. A good service plan also provides and outlines objectives. Basically, that refers to action steps. The action steps should be a way of breaking down the goals to tell who's going to do what, when it's going to be done, maybe how it's going to be done, and these action steps or objectives combined lead to achievement of each goal. A good service plan is realistic, it's achievable, but above everything else, it's something that the family wants to accomplish. It's not what you want of them. It's not what the social worker wants of them. They are, well, hopefully those are components too, but they're things that the family says, this is what we want to achieve, and we're willing to take the necessary steps to accomplish that. At the first meeting with the family, after you've completed the service plan and after you've gotten their signatures, you should bring to them enough copies of it that you can give one to each adult and adolescent family member. Sometimes if I do have one of those younger children who's really excited about the whole process, I'll give them a copy of it too. So I like to have family members feel as involved in the process as possible. Yes? Question?
So I hear you saying that the goals should encompass what the referral has required and the family members, all of the family members as well. Could you give an example of what would be an attainable, typical kind of goal and what would not be?
Well, off the cuff, that's a little bit challenging, but let's say that the issue has been that, we have a single mom, and the only way that she can go to work when she doesn't have child care is to leave the children unattended. And that's what led to the referral in the first place. So a reasonable goal might be that the children would be supervised appropriately at all times. Now, you might not say it in that way, but that might be a reasonable goal to work towards. You would help the mom and other members of the family come up with alternatives to leaving that child unsupervised. And now, you might just say, if, like, from your perspective or perhaps from the referring social worker's perspective, this won't happen. Mom won't leave. Susie won't be left unsupervised or something like that. That wouldn't be very realistic. It wouldn't be very achievable because the odds are if Mom could already do that, she wouldn't be leaving Susie unattended. By helping her come up with some options and by developing a plan, say we will contact such and such child care provider, or we will go to CSO to see if you're eligible for funding for child care services, or we will contact Susie's dad and see if he has some ideas about someplace that she could stay. Those would be maybe some steps that could be taken in order to accomplish that. I'm not sure I addressed the intent of your question. Is that okay? So, another thing I want to point out about a service plan is when you finish with the family writing that first service plan and everybody signs it and you have a nice, attractive, professional-looking document that you forward to the social worker, that form is not engraved in stone. It's a dynamic document. It's going to be changing as the family situation changes. As they accomplish goals, you can take those off of the service plan. As new situations arise, you're going to add that to the service plan. You know, a lot of studies show that the optimal number of goals to work on, or maybe I should say the maximum number of goals to work on at any given time, is 3. But maybe you and the family identify 5 different goals they want to work on during the course of your intervention with them. So you pick the top 3 most important ones, the ones that are most specifically related to why the family was referred. And when you've helped the family accomplish one of those, then you go on to the next goal. So a service plan really should change to reflect what's going on in the lives of the family. When a goal is accomplished, celebrate it, document it, move on to another goal. Have a little, a little party. Bring cupcakes, or, take everybody out for a Coke or something like that. Celebrate accomplishment of a goal. Make a big deal of it. Little kids love it when you give them, gold stars or stickers or something like that. Of course, you wouldn't want to do anything that would be considered condescending or patronizing to the family. But in keeping with where they're at, let them know that they've accomplished something significant. Now, at the same time, if no progress is being made on a specific goal, discuss it with the family. Talk about why things aren't happening. There's a lot of reasons why goals fail. Consider what some of those may be. Here's where critical thinking is going to play a big part. Look at what part you might be playing in the lack of progress. Is this a goal that you wanted but the family really didn't? Was it too big and unrealistic? Or was it too small and demeaning? There's lots of reasons, again, why goals might not be accomplished. So talk about that with the family. Take another approach. Eliminate that goal if it's not something that's realistic. But when goals are accomplished, or if they're amended, or if you decide to throw them out, be sure that you're noting this, documenting it in your charting notes, talking with the social worker about it in your weekly updates with them, and also including this information in the monthly status report. Okay, community connections I want to move right into, because that's also an important part of developing and implementing the service plan. Because one of the primary functions of FPS is to help develop and enhance families' connections to the communities where they live and where they work. And of course, as we mentioned earlier, connection to community resources is one of those required outcomes that we are assessed as to how we're doing on those. So you will want to explore a number of issues with families, including what their needs really are, what kinds of resources might fulfill those needs, which of these kinds of resources are actually available in the family's community. Typically, the smaller the community you're working in, the fewer resources are available, and the more creative you have to be in helping connect families to resources that they need. Also, look at what barriers might be preventing a family from accessing resources. What other available resources might provide a reasonable alternative solution to the family's needs? If one of the issues is the family doesn't have appropriate winter clothing, we may automatically think of a clothing bank as where you turn to. Well, what if there isn't a clothing bank? What if the clothing bank doesn't have the right kinds of clothing to meet that particular family member's needs? Think outside the box. Think about other types of alternatives that might be available that could help the family deal with this specific need. Finally, think about what might be the benefits or possible disadvantages to linking the family with specific community resources. You know, I want to point out that I've done family preservation trainings for a number of years, and during that time I've talked with lots of providers all across the state. I've talked to some folks who say, you know, we provide to each client a list of all the available community resources. And that might be a nice thing to do, especially if you do help them figure out how to do the networking, how to actually access these resources and so on. But there can really be a negative side to that too, a disadvantage. If people are only thinking in terms of, where can I go to have this given to me? Or who will help me fix this? Then are we really helping them to become more self-sufficient? It's important to remember that a big, important aspect of our mission in FPS is to help families increase their level of self-sufficiency. That means not having to depend on others. So teaching them where to look and how to access resources within the community is an important first step. It provides them with valuable tools to help tackle present and future challenges, but it's not the end-all and the be-all. So don't just hand them a list of resources. Help families explore what options are out there. Show them how to use good judgment in determining what might be helpful, and do take those first steps with them to make that connection. It's always important to remember that our clients learn best when we do things with them, not when we do things for them. The key to remember here is that we're not just connecting families to community resources to solve whatever happens to be this immediate, presenting, one-time need. What we want to do is show families how they can respond to challenges in a healthy, positive way, and that ideally this is going to help prevent the need for intervention by Children's Administration in the future. That's what they want, that's what we want, that's what Children's Administration wants. Along with community resources, FPS does have one really wonderful aspect that a lot of other services don't have, and that's the availability of concrete goods and support services. A specific dollar amount is allotted to each FPS case. Currently, that's $500. The funds can be utilized basically at your discretion if you've obtained appropriate departmental approval. This means talking to the social worker, getting written authorization. We will talk about that more later. These concrete funds can be used for food, shelter, clothing, other necessary services. It can be used to pay utility bills, things like that. But there are specific conditions and exceptions to its availability. As I mentioned, we'll be talking about this in the billing and payment training module, so I'm not going to go into any detail about that right now. That particular training model also provides very specific step-by-step instructions on how to use, to obtain, and then to get reimbursement for concrete supports expenditures. So the last thing that I want to talk in this segment is about the use of paraprofessionals. The contract says, paraprofessional means any individual who is trained and qualified to provide assistance and community support systems development to families and who acts under the supervision of a preservation services therapist. The parapro is not intended to replace the role and responsibilities of the preservation services therapist. So if a parapro is involved in a case that you're working, it's your responsibility as the therapist to provide clinical support. You continue to be responsible for the case. You're the one who does all of the reporting, the service plan, the family assessment, if there's a safety plan that's generated by the provider, you're the one who does that. So the parapro is responsible for doing their own charting notes and keeping track of their hours. But outside of that, the FPS therapist continues to be responsible for all of the documentation and basically running the case in collaboration with, of course, the referring social worker. Typically, parapros are used for the types of activities or tasks where the level of skills and the level of credentialing of the therapist isn't necessarily required. For example, here are some ways in which parapros can be really effectively utilized. Teaching skills. And I give some examples here: budgeting, meal planning or nutrition, basic parenting skills, housekeeping, doing laundry, things like that. A friend of mine sometimes uses the example of teaching a teenager to drive. I'm not going to go there. I wouldn't suggest that to anyone. But any type of skill that a parapro can teach where the therapist level of expertise isn't required, using a parapro is very effective. Parapros can be used for providing emergency transportation when other options aren't available. Do want to point out that FPS should never be used as a taxi service, but there are occasions when the only option is for a client or a family member to be transported somewhere. That would be a great place to use a parapro. Another example would be in developing community connections. Taking clients out into the community, showing them what's available, teaching them how to access and to use these resources. One example that readily comes to mind is a family that doesn't have good transportation. If there's a bus system in that city, then the parapro can take the family members down to the bus station, get a pass, show them how to use the transportation system, where to catch the bus, how to understand the routes and the schedules and things like that. Great use of paraprofessional support. One reason using paraprofessionals is such a great idea is because the hourly rate we charge for a parapro is 1/3 that of the rate charged by a therapist. So, in other words, you can really maximize the number of direct service hours by using a parapro. Also, they can provide direct crisis coverage, backup coverage for the families that they're working with. So that's a nice way to give a little bit more flexibility in your crisis coverage schedule. Now, one thing that I want to point out, and this will be the last note before we take another break, the referring social worker has to authorize the use of paraprofessionals. On the referral form, there is a line that says, do you expect paraprofessionals to be used? Yes or no. If the therapist has checked yes, it doesn't necessarily mean that you have to, although you should clarify that with the social worker. If the therapist has checked no, it means you can't use a parapro unless the referring social worker either changes their mind or otherwise gives you written authorization to do that. If they didn't check yes or no, you need to clarify that with them. So if you didn't get the authorization to use a paraprofessional at the time of referral, make sure you've gotten that in writing before you introduce a parapro to the family. Okay, are there any questions about any of the things that we've covered in this segment? Then let's take a break and we'll get back shortly.